Dr. Jenkins, welcome
back.
Nice
to see you, Ed.
Nice to see you. It's like our weekly chat.
It is. It's a pleasure to be back.
First of all, I was thinking back, looking at our previous video, I had a lot of anxieties coming into kind of where we'd be now. I feel like we are in it now.
Yep.
How are you feeling in terms of what you thought you'd be at this stage and where we're at?
Well, I would say that it's probably approaching some kind of peak in the UK at the moment, and it's fair to say it's not quite as bad as we might have anticipated, so therefore we're assuming that all the amazing sort of social distancing measures that people have put their minds to over the last few weeks have started to work, and that instead of doing this, it's kind of done that. So as I'm sure you know, our intensive care units are busy. They are certainly way above capacity, their normal capacity, but they have expanded their capacity, so they're coping. On the wards that we're dealing with, I think we're managing at the moment, and as you've seen through ED, it's a sort of slow, steady stream rather than a overwhelming flood.
That's it. I mean, I feel like in the emergency department right now, I feel a little bit of a fraud because we are really operating at a similar capacity that we'd normally operate at. And that's a combination of having more staff there, but also people staying away for things that they would normally come into ED with. So we're kind of operating within our within the realm. So for me, I feel like it's much more of a ward issue, a capacity issue, and an ICU issue, which I don't see a lot of.
No, well, I think what I would say from the areas that I cover is that the busiest areas are the elderly care areas, because it's clear that it's impacting on the elderly in a big way. We're starting to see now the sort of potential waves in care homes, which I think is going to be a problem. Our elderly care wards are certainly busy, and we're struggling to sort of work out how to manage those. The area that I'm involved in is the respiratory ward, is involved in the ward for relatively younger, relatively fitted patients who are sort of potentially heading towards critical care. A name check for my excellent colleague Dr. Moore, who's been involved in setting that, has very much led that ward herself, but that's sort of working pretty well now. And that is not full by any means, that ward. So it seems to be manageable as things currently stand. I think the other question is directing the flow through a hospital. In other words, where do people go? How do you know who's got COVID, who hasn't? As you've seen, it's a difficult area, and I think all hospitals are struggling with this problem of, if you're waiting a little while for a test, where do you put somebody? So you have kind of like holding wards where you wait for test results, etc., etc.
That's certainly something that I picked up from the comments on the channel, that a lot of people are surprised about, offering kind of lots of solutions about it. But I think one of the biggest things is people don't realise that where we are, tests can take a few days. I know a lot of people have same-day testing, but even if testing is a few hours, there's still that potential to, if patients are cohorted together, that they could spread the infection.
They can, and I think the test is only 75 to 80% accurate, so you could still have a negative. So you've got to still use your sort of, you've got to be able to sort of clinically say, actually, this test might be wrong, which is another challenge to throw in. I think two issues really to think about now is, you mentioned the fact that people are not coming into hospital with other problems. Those problems are going to start to mount, and I think we've got to deal with that now. So I think we're probably at a point now where we need to start looking at making sure that people are not put off coming to hospital when they really need to come. And also, there's a lot of services that have closed that need to reopen. So that's the sort of bit to think about over the next few weeks, for sure.
I've noticed a direct impact on that first point in terms of patients coming in, much more complicated cases in A&E than I'd normally expect, because people are waiting too long, not presenting when they'd normally have, symptoms of a stroke or a heart attack or other serious infections. So that's one thing that we need to get home to the general public, that any other medical problems that we have, good treatments for, people shouldn't be at home and worry about coming in.
Especially now that we've got sort of your COVID versus non-COVID ED, so people hopefully can come with a greater degree of security now that they can be managed through a hopefully non-COVID pathway.
So one of the other things as well, we've seen a lot of COVID coming in now, where a few weeks ago we were just hearing stories of it, and now we're actually seeing it ourselves. And we obviously did that first video on what we knew so far. How has that changed now? What's your view on it now?
Well, I think we're all starting to recognise what the condition looks like. When we first spoke, we were sort of talking almost theoretically about what we thought this was, and it had the flavour of a viral pneumonia akin to influenza. I think now that we're seeing more of it, it seems to be quite an unusual condition, not like anything any of us have really seen before in the way it behaves. It certainly is different to even the sort of standard viral pneumonias that we've seen previously. And I think whether that reflects the fact it's such an unusual, novel virus for which we've not got any immunity, or whether it's just something specific to this virus is unclear.
So is that even different to things like SARS and MERS, or is it similar to that? But
that's a very good question. I think that we're not. That will come out. Sure. Actually, I actually don't know the answer to that, but we will see. Certainly, they are exhibiting some very unusual metabolic blood features. Quite a lot of incidents of clotting within the blood vessels, both within the lungs and without. So there seems to be triggering problems with clotting, which is unusual. And I think that this is about an immune response to a viral infection, and that immune response then triggers off other things within your blood that makes it perhaps more sticky and therefore prone to clots, and a whole host of other sort of metabolic and blood-related factors which are something that we're not used to seeing before. Therefore, what we're seeing at the moment is a whole host of ideas, theories about the mechanisms of the infection. We still don't have all the answers by any means. Therefore, it's very difficult to talk about treatments because we don't quite know what we're treating yet. There are clinical trials going on where most hospitals are taking part in trials to try and see whether there are any treatments that can help. At the moment, we're going to have to wait to see whether those are effective or not.
Right, so it's interesting to see that this is something that can cause a pandemic, but it also has some other thing about it. You know, we not necessarily recognised the virus before, but is the virus also doing something different? Is it triggering something different in the way we react to it? It'll be fascinating looking back and realise how much we're kind of scrabbling in the dark with this.
Undoubtedly, and I think we'll learn lots of new things. What does seem to be clear is that some people are more prone to bad effects than others, and we can talk in a second about what sort of people are more at risk. But what does seem to strike me as a key part of this is that, you know, we know the virus seems to bind to the what's called the ACE2 receptor, and I think you talked about that in previous videos with Sonia with the help of Lego. It is likely that the reason that some people do particularly badly with this is the way that their genes are, their genetic background predisposes them to having an unusual response to the virus binding, and so it's likely that some people are just unlucky in their genes, and that's why they get particularly badly ill. And I would say that would be particularly true for the rare cases that we see in younger people.
We've talked about the risk factors before, mainly age, but that's not the whole picture, is it? We talked about there being some other risk factors that we don't know about, so the way our immune system's primed or genetics. But what do we know in terms of other risk factors?
I guess the first thing to say is you've got to be infected. So before you can have a problem infection, you've got to get the germ inside you. So you always talk about infection versus host factors. So I guess the infection factor, you've got to be exposed to the virus. And you talked in a previous video, Ed, about this idea of infectious dose, which I found very interesting, which is that, are you more likely to get more seriously ill if you have a higher dose of virus versus a lower dose? And the assumption is that if you've got more virus particles coming in, your immune system struggles to cope with it, therefore there's more of them and they grow quicker. And as you pointed out, there's no definite evidence for that apart from sort of experimental evidence, but it seems to make sense. It seems to explain why certain types of medical professionals seem to be perhaps at risk, people who are involved in what we talk about aerosol generating procedures, or people working in close and personal with a patient. So specialties like ENT and anaesthetics perhaps might be at particular risk.
The other sort of anecdotal thing I heard was a married couple where one of them ended up on ITU, and then a few days later, obviously they're not genetically related. But could they have, one of them had quite a high dose and then exposed the other? But that just may be an anomaly given the number of people that have it now.
No, we've seen a number of people where it seems to be within households people becoming seriously ill, so that it's difficult to work out what that would be. I think the other area where infectious dose is important is that if you are unaware that you're being with a person who's got the virus, you're more likely to spend more time with them, therefore you're more likely to have a higher infectious dose. And I think this is the importance of social distancing, that without social distancing you're not going to have the ability to make that distinction. And I think we should think about people who've been involved in frontline jobs, not medical. So you've seen the story about bus drivers, other key workers who've not had any form of PPE at all, but have likely been exposed inadvertently to higher levels. So I do think inadvertent exposure is a really strong risk factor that we need to think about. In many ways, in medical situations, I don't know if you feel this, once you know what you're dealing with and you're using PPE appropriately, as long as you can get it. And it's fair to say at the moment, my experience is that we are getting it.
It's not necessarily the experience we hear about our other colleagues.
And I think that's not true everywhere, and I think it's still been very patchy. But if you are adequately using PPE, it is likely that whilst you may have some exposure to the virus, you would hope that it would be at a smaller level.
That is really my hope with the PPE, because obviously you try and mitigate it as much to not get exposed at work, but then again you're still kind of walking through the hospital, still using things. You try it as little as possible, but also you're still getting some exposure at home, whether you're shopping or whatever. I realise that it's just about reducing that dose if at all possible.
So I suppose since we last spoke, we've seen a lot of health professionals sadly die from the condition, and that's been quite a tough thing to see, isn't it? How has that made you feel? It has.
I mean, we've brought up this discussion last time. When I was looking back at the edit, I think you asked me the question, have you thought about your mortality? And I hadn't. Only when I was looking back at the edit and I was like, should I? I just was very oblivious. But now, particularly because we've had, I think, some people in their 30s, haven't we? And so now I am thinking, well, it is a worry for me.
Yeah.
I'm not sure how it changes what I do, but
I think we've got to. What I would say is that each case is tragic in its own rights, isn't it? And I think it really hits home when you see the people in the service affected. I guess what I would say again, which goes back to the message from last time round, is that the risks are also shared by people in the general population, and actually it may well be, if you look at the risks to medical personnel, they are clearly more than they are in the in most of the population. But if you look at some of the data from, let's say, a country like Italy, it's probably not quite as high as you would think. And for instance, the death rate for doctors is not necessarily bigger than it is for the general population in Italy, which is interesting. However, you need to factor that they are of a certain age group. So if you factor that particular point into account, I think they're still overrepresented, which is perhaps inevitable because of the nature of the work. I think the other factor in Italy was that at the beginning of their problems, there wasn't an awareness of what was going on, so they had a lot of people exposed at the beginning. So to me, it's all about knowledge of your likely exposures. If you can control that and understand what you're dealing with, you can certainly reduce your risks considerably. But you can't make them zero.
And one thing I wanted to mention as well is that, obviously we feel like the number of deaths is plateauing. So by all accounts, things are, we're right in the peak at the moment. But because of this flattening the curve, the peak is not just going to be a few weeks. This is going to be over many, many months. So we could potentially be working at this level.
I think for quite a while, yeah. I mean, I think the death data is also quite difficult to interpret because the number of deaths you get reported today, many of them happened several days ago. So that makes it a little bit more difficult to interpret. We are going to have to get used to operating in, as we said before, an environment where Covid-19 is still around as an important clinical problem, but we need to start getting on with other things as well.
Post-COVID world.
Yeah.
Like a dystopian future we find ourselves in. So we talked about exposure factors. Let's move on to the host factors then. What do we know so far about who's likely to be at risk of?
So I think number one on the list, as everyone's, has got to be age, hasn't it? I mean, I think it's so clear cut to all of us. You can see that in day to day. You can see that in the data. We did talk quite a lot about that last time round, and I just wanted to sort of come back to that. I think we quoted in the last video I did with you that in Italy no one under 30 had died from COVID-19. In the UK, I can give you some figures from up to a few days ago, and obviously there's a bit of a time lag, but we did have 82 deaths in people in the age range of 20 to 40. And in fact, 8 deaths in people under 20. So slightly more than you'd see in Italy. And corresponding data for Italy, as far as I could see, was that 8 deaths in total in people under 30. So, these are rare events, relatively speaking, whereas, the corresponding figures for the UK, over 5,000 deaths in people over 80, 4,000 deaths in people in the 60 to 80 age group. Bearing in mind, as we get the data on deaths from care homes, that will skew that further. So, age is, by far the strongest risk factor. I think we have to assume that, susceptibility to infections is higher. What isn't quite clear is why you normally associate older age with reduced immune responses, and yet the people who have severe outcomes have a over-exaggerated immune response. So there's something there that doesn't quite add up as yet. I think that will come out.
That's interesting, because I was asked that question by a medical student yesterday. Why, if you're on immune suppressants, are you more likely to get... I guess because we have 2 factors, right? This is how I answered it, probably wrongly. But you have to look like you're an expert when you're chatting to a student. So I've said, well, there's very much the infection itself and the immune thing. So if you're immune suppressed, then the infections
can overwhelm.
You're going to get that side of it much more. And that's what we worry about. Then I said this secondary thing, who knows if there's going to be some kind of immunotherapy that supports that secondary phase.
And I think at the moment we don't see people with classical immune deficiencies being particularly affected in the numbers, but in a sense they're considered a risk factor and at-risk group, so they're part of the group that have been asked to shield. Sure. But we don't necessarily find that they're strongly showing up in the numbers as yet. I think the other risk factor we have to talk about is sex. So we're all seeing that it's very much male-dominated. So I think the ratio I saw was 2.7 males for every 1 female who's badly affected. So it's almost 3 times as common, severely affected in males. And that's pretty unusual for infectious diseases, which tend to be pretty 50-50. So some of the differences could be about behaviour. In other words, men tend to present later with their illnesses. But this seems to be
but
so
even regarding
that,
those things,
I mean, I don't think anybody knows the answer to this. There is some thought that there might be higher levels of expression of ACE2 in males, for instance, that might give a more target for the virus to attack. I think there's various suggestions that hormonal factors, whether it's estrogen or some of the androgens, influence immune responses. So it's going to be something around that explains the difference. But it's such a striking difference. There's got to be a clear explanation for that at some point.
And you're right. I mean, I've noticed, I picked up on that already. Obviously, I've read about those risk factors. But when someone comes into hospital and it's a gentleman in his 60s with the symptoms, my heart sinks. Because they're really going to potentially struggle.
The other area that is receiving quite a lot of publicity at the moment is about ethnicity, and it really cuts to the chase, I think, of the mystery of COVID and what we don't know, and what little we do know. So if you look at the very sad stories of doctors in the UK who've died from COVID, almost all of them have been from BME backgrounds. So it is clearly an effect. I think if you look at the data from our intensive care network in the UK, about 36% of people who've been on intensive care are from black or ethnic minority or Asian ethnic minority backgrounds, which is much higher than the general population and much higher than similar cohorts from previously due to influenza. So it seems as though something is going on, and it's not clear what. I think there is likely to be a number of different factors, some of which may well be reflections of our society and what's going on in society, and some of it may be sort of biologic things. So I think, as you've seen, the the epidemic seemed to sort of kick off very much in London and West Midlands, so it may be that a lot of it is just about the geography of that.
So on the socio-economic thing, so these are people that we don't know there's a genetic link, or they're people that live in more, crowded areas, or they're people that do jobs that expose them to more...
Undoubtedly, and I think people will be more likely to be working as key workers, they're more likely to have to keep the ship afloat, more likely to be on the tube, etc., etc. And then other factors that can come into play maybe around, people talked about multi-generational households, etc., etc. So being able to, younger people transmitting it on to older people, overcrowded housing, living in cities. So those are all factors that are very difficult to tease that out.
Yeah. And we see that in other diseases, don't we? Like TB and things like that. We'll see them, infectious disease, spread a lot more than like. I found it really interesting, actually. Did you see Emily Matis's intro on Newsnight?
Oh, it's amazing, yeah.
Because that really highlighted a huge misconception. A lot of people say that this disease doesn't discriminate. But of course, the world is not fair. So we know, even just the socio-economic factors, we are seeing people from poorer backgrounds are going to struggle. I mean, this is in the UK where we have access to healthcare. God knows what it's like elsewhere. But if we just focus on here, these are people that are going to be living in flats. These are going to be people that are doing those jobs that are exposed. It's very different, even being in isolation in a your house with a nice
cozy garden. Oh, massively. And I think we've seen that, and I think that's what's caused this sort of very rapid amplification in London, and the same factors seeing in New York. It's worth saying in America as well, they are seeing, particularly in the African American communities, big rates of COVID. So the other question that comes up is, how much on top of those obvious sort of socio cultural factors, is there also a biologic thing as well? Is it that actually the virus is attacking certain populations more, and we simply don't know the answer to that. Is it possible that we know that hypertension and diabetes are more common in South Asians and in Afro-Caribbeans? Is it possible that something in that is also a common factor that allows the virus to bind to the ACE receptor, for instance? So these are things that will hopefully become clear in as we look at it in more detail.
And these are definitely possible. We see them in other things. We treat hypertension differently in different ethnicities, don't we?
Yeah,
based on those receptors and based on how...
Absolutely, and I think, but as you pointed out, for all conditions, teasing out the sort of gene-environment interactions is complex, and it's not like one thing. I think it's like a whole host of factors that sort of add in.
And we're going to then talk about some other risk factors.
Yeah, so I think smoking is one that, if I'm honest with you, I really don't know about smoking. I'll sort of bring in respiratory conditions as well.
I've heard it's quite bad, actually. Have you not?
Yeah. So no doubt that smoking is bad for you. So in China, they did report that the outcomes were worse in smokers. So I think that we're assuming that smoking is a bad thing in relation to your outcome from Covid-19. I think the patients that we're seeing are not particularly smokers that I'm seeing. So it's not the sort of cohort of patients you might have imagined with bad lung disease, emphysema, sort of heavy smokers. Those are not the ones that I'm seeing coming through the door. I'm sure you're seeing the same thing. So
absolutely right.
I think probably if you get the condition and you are a smoker, maybe you'll have a worse outcome. But whether smoking is a risk factor for developing it in the first place, I'm not sure. We need a bit more data on that to see.
And it might be that people with that sort of more severe end of the lung disease from smoking are the people that are shielding, and so they're not necessarily exposed.
I think hopefully at the moment that's certainly the case. But what has struck me in the group of patients I look after with chronic respiratory disease, and there's a big group of patients, there's lots of them out there, we are not seeing them come in as affected by COVID as much as we'd expected. So yeah, as you say, the shielding is probably having an effect, but there's also a question about whether maybe the way that their lung disease stops them, the way their immunity in their lungs works may move against them having the bad response to COVID that you see in other people.
Right.
But that does bring us on to where we do see very clear risk factors, and this is perhaps unexpected, it was first seen in the Chinese data, is cardiovascular type risk factors, so diabetes, blood pressure, heart disease, possibly sleep apnea. So all these conditions, and certainly obesity. So obesity itself increases your risk, about doubles your risk of bad outcomes. So and you must have seen this. These are the patients, you can sort of see it where that's the problem.
Yeah, I mean, I just didn't realise it'd be that extreme. And that goes against just people being obese, having that extra disease burden. Very much that something else is going on.
Yeah, so it's not just that you've got the pneumonia but you struggle to breathe because you've got all this tummy there. Yeah, no, I think it does seem to be more than that, and it must come back to the underlying mechanism of the infection, where it binds, and whether that particular process is facilitated by whether it's just having diabetes and high blood pressure, whether it's the medications, or whether it's just a shared gene between those two conditions. It could be just around separate pathways with a shared gene. So air pollution is talked about as well, because that's another of those things that happens in big cities, and it adds to all these other factors that we talked about earlier about city living. Is it possible that air pollution is a factor? And if you imagine if you are living in London, you lived in London before, haven't you?
Yep.
You know what it's like, and you know what it looks like when you blow your nose. So if you're inhaling, all those gases and all the diesel particulates, we know that causes inflammation in the lungs. So we certainly know that it can worsen inflammation in response to other stimuli in the lung, let's say like allergens or infections. So is it possible that high pollution loads are acting as an amplifier for the response to virus? And again, you can certainly correlate cases with areas of high pollution, but it's not a causation because of so many other factors come to play. So we will see with that. I think that's the problem with pollution research, is that there's so many confounding factors, very difficult to tell, but it may well be an amplifying factor. And I think the other area we've got to look at is care homes, because I guess the issue about people in care homes is that they don't have the ability to control their environment.
Sure.
They've got people coming in, and the carers coming in to visit, and so both the staff and the carers are high risk, and I think we're going to see a lot of cases there, and I'm not sure how easily that can be controlled. I think there's no doubt that we were slow as a country to put PPE into care homes, and I'm going to see the effects of that. But I think it's just something that's going to have to be managed now.
This is it. Well, you cannot you can have zero risk if you just lock yourself in a cellar and have everything. But everyone has some risk because they have to get shopping, mail delivered. But then the risk will just increase massively if you have people coming that physically need to care for you, physically need to dress you, wash you, and you're likely to be of the age group that's going to be at risk. So it's a real, multi-factor issue, isn't it? That we're not going to solve. It will help getting the PPE, but as we said before, it's all about just trying to reduce the risk. We can't get it to zero, but what can we do?
I'm going to throw in another curveball that you sent me, actually, Ed, which was about a vaccination. So we obviously will be waiting to hear about the vaccine for Covid-19, but you mentioned about a vaccine called BCG, which is one that we've traditionally used for tuberculosis. And it's a VCG and a vaccine that we all used to get as youngsters. Did you get BCG?
I did, yeah. I was surprised. I didn't realise they'd stopped doing it.
Yeah, I mean, it's actually a fairly useless vaccine. Well, I say useless. It's not particularly effective for TB. It doesn't stop it completely. Fine. It reduces incidence. But
this is an example, I guess, of herd immunity, in a sense that so many people have had the vaccine now, right? That
yes,
we don't need to have it anymore. So
I think that's that. I think that's absolutely right. And I think incidence of TB is low enough now. BCG it does cause a change in the way your immune system works. Interesting. So it's basically a sort of cousin of TB, and it does skew your immune system in a certain way. Okay. So theoretically, it could influence things in a non-specific way. I would say it may just be an association rather than anything else. Now, I want to sort of throw in an interesting area, which is vitamin D. So I'm sure you've heard lots of stuff about vitamin D and health conditions, and it is thought to cause lots of things. When you actually look at some of the intervention studies in vitamin D, they're often negative, so replacing vitamin D doesn't always work. But vitamin D in viruses is very interesting. We know that it's very closely involved in immune responses to TB, and that's why the old TB hospitals, of which this was the last purpose-built sanatorium, this hospital.
Wow. Okay.
In fact, if you look at the wards over there with the
open windows.
So it's actually a Art Deco sanatorium, this hospital. So they used to treat TB with sunlight. So vitamin D in the form of sunlight, can help with certain infectious diseases. There's a big question about whether vitamin D deficiency predisposes to viral infections. I think there's some evidence in favour of that. There's also some evidence in favour of vitamin D supplementation being able to reduce your risk of picking up standard viral respiratory infections. Right. And I have to confess here that I do take cod liver oil, so I am, trying to practice that.
Not sponsored.
So I think that, and I think we simply don't know at the moment, but there have been suggestions that vitamin D deficiency might be a risk factor for severe outcomes.
But that's you think that's more viral disease in general?
And this is an example of that,
Fine, yeah.
So it may not be specific to the sort of COVID thing, but it's just that it might increase your susceptibility and outcomes. So I think it's a theory, an interesting one that I think is worth looking at, and we will see. But certainly it could connect to some of these other risk factors, including ethnicity. There is an argument that, for instance, in Spain and Italy, older men who've been very much at risk traditionally have been shown to be vitamin D deficient, so it's an interesting area to look at.
Okay. It also supports one of my mad ideas for the hospital, which I've not got a response back from the CEO. I thought, given the only thing we know that kills COVID is UV light, I thought that we could bring patients out on the beds and just have them outside for many hours a day, and then bring them, because they're getting the vitamin D, the UV, they're getting the air, because we know that breathless, one of the only evidence-based things is having a fan, get a nice bit of wind. Yeah.
Prone lying as well, is that so?
There's sunbathing.
Well, I mean,
we're mad.
It is, I don't think that is mad, and I think it is interesting that it was the actual origin of this place, and we'll see.
Is that going to happen then?
I think that we'll see what the bosses say.
Thank you very much, Dr. Jenkins, again.
Pleasure, Ed.
I guess I'll see you next week. We'll have another chat about things.
I'll look forward to it.